Hello, everyone. Welcome to the Healthy Families, Healthy Kids Policy, Practice, and Equity for Thriving Young Families. Thank you for being here. We're excited to tackle issues central to families in Texas, such as addressing our state's maternal mortality rate, debate and legislative actions on the Medicaid expansion in Texas, how to support new fathers, social determinants of health and health disparities for young children and new parents, and health equity and outcomes across race and class. We're happy you all could join us today on Veterans Day. We can keep veterans and military families in mind today as we think through together the best ways to support all families from all different backgrounds. My name is Johanna Luttrell. I'm the Assistant Director of the Elizabeth D. Rockwell Center on Ethics and Leadership at the Hobby School of Public Affairs. This event is co-sponsored by the Rockwell Center and the Center for Civic and Public Policy Improvement. The structure of our day today will go like this. Right now, we have Dr. McLean Sampson and Eulalia Gillum from Healthy Start UH to speak about the work that Healthy Start is doing here and introduce issues around maternal, child, and father's health. Then at 9:30, we have a panel of local impactors, folks doing work in NGOs around Texas in the area of maternal health, fatherhood involvement, domestic violence, foster care, and early childhood emotional development. After each panel, we'll have time to network and process in a different Zoom room than this webinar. And the link for that Zoom room will be provided in the chat. We invite you to join the Zoom session if you can, no pressure. It's more informal and participatory. And it can be a good opportunity to meet others working in this field and thinking about this issues and others who are on the call here besides panelists. We'll have a break then, and then at noon, we'll return to our second panel, our Texas Legislative panel, with Representative Donna Howard, Representative Garnett Coleman, and Representative Sean Thierry to discuss policies to help families. After the legislative panel, we'll meet again in the same Zoom room, but different from the webinar, and have interactive time to process that panel and also to act together on calls to action around family and child health. Before I begin, I'd like to thank our incredible team working on this, Jordan Bocelli Everett at CCPPI, Emily Janowski, our assistant to the dean here at Hobby School, Chelsea O'Hara at the Hobby School, and our MPP student, Kate Ranashan, and the UHIT department, and many others. We had a good time working together on the team for this conference, and I felt myself really blessed to be able to work with such caring and thoughtful people on this. Now I'd like to introduce you to Dr. McLean Sampson and Eulalia Gillum from Healthy Start UH. Healthy Start is a national program that helps improve the lives of mothers and infants and families before, during, and after pregnancy through coordinated care case management, home visits, and outreach and education. Healthy Start seeks to reduce infant and maternal mortality rates, increase access to prenatal care, and remove barriers to service. Houston has a high rate of infant and maternal mortality, with Black mothers being most at risk. Dr. McLean Sampson is Healthy Start UH's principal investigator, associate professor, and center direct, and Eulalia Gillum is the program director. Thank you both for being here so much, and we welcome you. I believe Healthy Start has a short video to play, and then after the video, McLean and Eulalia, you can go right ahead. That's all right.
Okay, thank you so much. Are the panelists, are you guys playing the video or are we?
We have the video all ready to go here.
Okay, thank you. The current state of healthcare for mothers in the U.S. is likely a result of good intentions but major flaws in execution. We have the highest maternal mortality rate out of all industrialized countries, and Black women are suffering the brunt of that with disproportionately higher death and morbidity rates. We also have about 1 in 9 women experiencing perinatal mood disorders such as depression, anxiety, and OCD. Well, when we look into why we have these horrible outcomes, what we're seeing is fragmented systems of care as far as female reproductive health care and birthing care, but also fragmented insurance care. and lots of misinformation is happening for moms as far as prenatal and postpartum care. We also know that social determinants of health like poverty, discrimination, dangerous living conditions are contributing to these morbidities and mortalities for our moms. Well, the mission of the center is to improve the health of mothers and their families through interdisciplinary research and training. So we're really hoping that by bringing the community into our conversations as well as different disciplines, we can come up with creative solutions to meet mothers where they are and help improve health.
The Healthy Start program is a national program funded by the Health Resources and Services Administration, often referred to as HRSA. The program works to improve women's health, promote family well-being, encourage and promote collective impact within communities.
The community needs a program like Healthy Start because our program goes into homes of individuals and works with the family as a whole, with moms, fathers, babies, and we connect them to services. We really try to do that in a respectful, meaningful manner that will help the families work with us to uncover barriers that may not be conducive to them getting maternal health care.
My experience with Healthy Start was very positive. The caseworker that I have, she helps me keep up with my doctor's day, anything concerning the baby, even helping you further your education. They also, at this point in particular time with the pandemic going on, they're shoulder to lean on and an ear to talk to all the time, and just any problems that you're having, you can always talk to them about them. I've been with them for about 3 months now, and it's been going very well.
The center has such great passion and so many great ideas and things that are really coming to fruition that it's going to be great for us to be a part of that, being in the University of Houston College of Medicine and in the communities around us. A lot of what I've seen is a lot more collaboration, which I think is crucial to the effective improvement of health and healthcare of our women in our communities.
We here at the College of Medicine understand that health happens where people live, work, worship, and play. And the only way that we're going to be able to achieve those goals is through collaboration with community partners, such as the Maternal Health Equity Research and Training Center.
I think the future of maternal care needs to look like the collective efforts of all programs that work in the area of maternal and child health. I also think the future of maternal care needs to look like more services being offered to pregnant women through telehealth as an option, but also continuing to address the issue of systemic racism.
To have a future that has health equity for mothers, we really need to keep that framework in mind where everybody has a chance for optimal health during pregnancy and beyond. So we have to look at what are the barriers to optimal and equal equity. And what we see is that people need to focus on reducing the barriers to increase the equity barriers such as poverty, structural racism, implicit bias when providers are interacting with moms. We have a lot of repair to do in the community as far as building trust. I think that is something measurable we would see to know we're working towards equity. The role the center will play in achieving health equity for mothers is really helping to change the narrative about how we talk about maternal health. We know what the problems are. We've had plenty of research about that to show these disparities. We need to be focused on the solutions and including mothers' voices to help them feel empowered in their own health. Thank you for playing that video. Thank you. I see that I'm on now. Hi, I'm McLean Sampson. I, as the video said, am an associate professor at the Graduate College of Social Work. And I'm really excited to know that there are so many people here today who are invested in maternal health equity. It is a passion of mine for sure. What I'm going to do is provide some information and overview of Healthy Start. I'm starting my timer so I don't cut off my partner here. I'm going to provide a brief overview and talk about maternal mortality and morbidity in Texas to kind of set our framework for today. So Healthy Start is a national program, as you heard on the video, and it has over 100 sites right now that are funded across 35 cities. And the Graduate College of Social Work is the home of the UH Healthy Start. The reason I wanted social work to be the home for this kind of program is because I really wanted to build a program that is person-centered. And social work, that's what we do. We try to find out what the person needs and what is stopping them from what they need. So we're coming from that positionality, and we always have social justice that drives our decision-making as well. Healthy Start seeks to decrease infant mortality rates and maternal mortality rates by improving the health of moms, babies, and families. Now, we do this in a community embedded approach that our program director will talk about in more detail in a few minutes, but it is important to keep in mind that it's a community embedded program. So we're always looking for partnerships, and some of you may be on this call today, and we want you to keep that in mind. If you're interested in being a part of our program on the public impact side, and or if you're interested in being a part of the center. This program serves 10 zip codes that have been identified as having infant mortality rates twice as high as the national average. So what is maternal mortality? Maternal mortality is considered death during pregnancy or death up to 42 days after birth. You wouldn't think this, but the US has the highest maternal mortality rate out of all industrialized countries. And in Texas, we are running alongside that rate with 18 deaths out of 100,000. It has not really decreased in the last few years, and the data that we have to help us make informed decisions lags behind. So even when I'm giving you these statistics, it's at least a few years behind. Moms who are Black and moms who are Hispanic are bearing the brunt of these deaths, with Black moms dying at about 2 to 3 times the rate, and Hispanic moms on average dying about twice as high as white counterparts. We will talk a little bit about this, but we all need to be, as far as the why, but we all need to be engaged in figuring out the why. The infant mortality rate in Harris County is 6 out of 1,000, 6 babies dying out of 1,000. That's twice as high as Travis County. And also when we pull these rates apart, we see major racial disparities. Why? Factors related to provider and facility are cited as the top contributing factors of maternal mortality and morbidity when the state maternal mortality morbidity review task force did a study. That's what they found, is that the provider and facility are top contributors. These contributors are even stronger for women of color. Another strong contributing factor are things like social determinants of health. So we've got provider interaction and social determinants of health that if I were to recommend anything, it's zeroing in on that. Okay, let me talk for 1 second. I'm sorry, I'm still kind of getting organized after I had trouble getting on. I'm sorry, I'm a little frazzled. Okay. So another shocking statistic I wanted to point out to you is that the CDC points out that even for Black women who have college degrees, they're dying at 5 times the rate as their white counterparts during pregnancy and postpartum. So what can we do about this? Healthy Start offers solutions that we will talk about specifically, but broadly what I want to tell you, Healthy Start is seeking to serve 600 women a year. Half of those should be pregnant and 100 dads. So when you think about the potential impact that can have, it could actually move the needle in our city and in our county. We seek to synthesize and organize and mobilize existing efforts that are already going on with mothers who are pregnant and postpartum. We actually have quite a big safety net in Harris County, but we are also fragmented and not tied together. So Healthy Start is really trying to pull a lot of those efforts together by centering the woman and her experience and connecting her to other programs. Another thing I would like us to all do is to focus on eliminating barriers. We cannot have optimal health for everyone while we have so many systemic and individual-based barriers. For example, barriers to consistent health coverage during pregnancy and all the way up through at least first year postpartum, because we know that almost half of deaths for moms happen after after childbirth. So there's an important window there that we are missing when we have this fragmented care and women aren't coming in for their postpartum checkups. We also reduce barriers by bringing in fathers. Fathers have been left out of the discussion and out of solutions for a while, and our fantastic fatherhood program involvement coordinator will be talking on a panel a little bit later. We also reduce barriers by working with providers in federally qualified health centers specifically to try to assess and improve any potential miscommunications. As I said in the video, we have a lot of mistrust that we're encountering as far as social service providers and healthcare providers. So by working with the families and also working on the policy side, Healthy Start is able to work towards systemic change, which I think is going to be extremely important to address this problem. So I would like to now turn it over to my program director. Ms. Eulalia Gillum is very experienced in working with Healthy Start, and she's been serving as the program director since our site was funded, which was in spring of 2019. Thank you.
Good morning, everyone, and happy Thursday. Happy fall. I apologize in advance for this bizarre glare that's coming from my eyeglasses, but I'm at that station in life where they're just necessary. So I want to share just a little bit more about the Healthy Start initiative and specifically the project here at the University of Houston beyond what Dr. Sampson has shared. The Healthy Start initiative has been in existence since 1991, thanks to our former late great Congressman Elijah Cummings. But it didn't start from a positive place. It started from the fact that the city of Baltimore that he represented the majority of had infant death rates that were the highest, first of all, in the entire United States, but that also exceeded that of many third world countries. And so that's alarming when you really stop and sit back and just kind of process that. So unfortunately, here in the city of Houston and Harris County, we have found ourselves in a very similar situation in that we now, unfortunately, have the highest infant death rates of any county in the state of Texas. So the initiative itself, which is the broader scope of Healthy Start, which is inclusive of the other 100 funded sites throughout the country. They utilize 4 core components to address the issues of infant deaths as well as now maternal deaths and morbidities. And those 4 components include improving women's health, improving family health and wellness, promoting systems change, and assuring impact and effectiveness. So those are the broader components, but what does that look like at the local level of any Healthy Start project? Well, I think Dr. Sampson touched on some of this. So at the local level, we have outreach and recruitment that we actively engage in. And so that literally means that we have staff who are devoted solely for the purpose of going out into the community, and not only identifying individuals, moms, babies, fathers who are interested in our program, because it is a no cost program and it is completely voluntary, but that also includes engaging community partners. And that looks like everything from large hospital systems to healthcare systems that are community-based and provide obstetric and gynecology as well as pediatric care services. It looks like other community-based organizations, other academic institutions, and definitely programs and organizations that work with and fight for our fathers and men, because unfortunately they have simply been the forgotten population. And up until 2014, they were kind of not factored into the bigger picture, but they are very much a vital part of any baby being conceived. And then also we want fathers and men to understand the role that they play in the growth and development of any baby from conception all the way to birth and beyond, because our goal is that we see every baby live to see its first birthday. We also have case management services. This initiative was designed to be a home visiting program or initiative. Well, the pandemic does change that a little bit when everyone was ordered to go home and stay inside and lock the doors. But we found ourselves in a unique position in that we were able to become really creative and innovative in the way that those services were provided. And we have continued to keep some of those innovations to date, and that we now have a virtual component as an option for interfacing with and caring for our families, providing them with the social and supportive services and health education that they desire to have when they enroll into and receive services through the Healthy Start Project. There's health education. We use an amazing evidence-based curriculum, which is Growing Great Kids, and it is literally designed for home visiting or case management projects or models. We've been very fortunate to have a clinical practitioner be able to join our team. We have a nurse, and so her role specifically is to care for, as a supplement, all of our high-risk pregnant moms, but then all of those babies that have been born with factors that have made them now high risk. That could include a baby being born premature, low birth weight, very low birth weight, an infant that is failing to thrive for a number of reasons. And the practitioner in no way takes the place of the provider, but actually a part of her role is to reiterate the importance of the pregnant woman not only establishing a medical home and beginning prenatal care, but ensuring that she continues prenatal care throughout the course of her pregnancy and that is adequate. We provide depression screening for all of our moms. I'm using the Edinburgh postnatal depression screening tool. And of course, we have our Community Action Network, which a number of you all today serve on or have chosen to become members of. If you have a greater interest in engaging, please do reach out to us. We'd be happy to connect you with our Community Action Network manager. And it is in essence a consortium of providers, of community partners, of community participants and program participants who have come to the table for the sole purpose of addressing issues specific to infant mortality as well as maternal morbidity and mortality. And then our fatherhood component, we're going to hear from our fatherhood involvement practitioner, Mr. Cal Jobert, in greater detail a little later this morning. And what we really hope to do through this project here in Houston, but I would also yield to the other Healthy Start projects through the country, is begin to change the narrative about the role of fathers, and specifically Black fathers and Black men and their involvement in families, in caring for babies, and in supporting mothers, not only through pregnancy, but beyond. I believe that this is a labor of love for anyone who endeavors to work in this realm of maternal and child health. And for those of you all who may not be aware, the overall health of a community is largely associated to the rate at which babies are dying within that community. So not only are we endeavoring to make a difference in the lives of women, babies, fathers, but ultimately we are endeavoring to make a difference and change the dynamics in the health of communities here in the greater Houston area and in Harris County. And for more information, please don't hesitate to reach out to us. We are there within the University of Houston's greater website. Our contact number is 713-743-5500. Our email address is hsi@central.uh.edu, and I'll be happy to post this information in the chat room for anyone that is interested. But I would like to certainly thank the Hobby School and Dr. Luttrell and her amazing team for organizing today, but also for affording us the opportunity to not only speak more about the issue of infant mortality and maternal morbidity mortality, but also to increase the awareness and the existence of the Healthy Start project here at the University of Houston. And so thank you all very much.
Thank you so much. Thank you so much, Eulalia and McLean. Thank you. It's such an honor to have you here at this conference, and the work that you do is so important, and we're glad to support it. And to have the work thrive, and to have families that you're working with thrive, and the babies. Now we move on to our first panel, which is a panel of local impactors. So I'm going to hand the mic over to Jordan Pacelli Everett from CCPPI to introduce the panel. Jordan, go ahead.
Thanks, Dr. Luttrell. Hi, everyone. Welcome to our first panel of the day. My name is Jordan Pacelli Everett, and I work at the Center for Civic and Public Policy Improvement, or CCPPI. CCPPI is dedicated to advancing policies that promote human, civic, social, and economic justice, and taking the necessary action to affect progress in the areas of healthcare and health, affordable housing, criminal justice and safety, and education. And prior to joining CCPPI, I worked in the domestic and sexual violence prevention and advocacy field for 10 years. And survivors of violence are impacted by policies that keep them from accessing healthcare coverage, stable housing, and employment opportunities so that they and their children can be healthy and well. We are so excited at CCPPI to have been able to work with our partners at the UH Hobby School to put on Healthy Parents, Healthy Kids, policy, practice, and equity for thriving young families for you today. And I have the honor of introducing you to a group of 4 incredible local impactors who are out there doing the work to improve the health of families in our Houston community and beyond. So first we have Mari Carmen Garza. Mari Carmen is the Chief of Programs at Tahirih Justice Center, a national organization that serves immigrant survivors fleeing gender-based violence. Mari Carmen previously held a 21-year tenure with Texas Rio Grande Legal Aid, or TRALA. As an attorney, Mari Carmen focused her legal practice on assisting survivors of gender-based violence with complex family law and victim privacy matters. She initiated and managed one of Trala's most successful and long-standing projects, a unique collaboration between Trala and domestic violence shelters and rape crisis centers in the 68 Texas counties served by Trala. Amongst multiple other leadership roles, Mari Carmen was nominated as a leader of color for her experience and expertise in working at the intersections of domestic violence, child welfare, and race equity to join Texas Working at the Intersection for Safe Families, or Texas Ways. She will share the work she's been doing with Texas Ways today. Next, we have Naomi Kadima. Naomi is the Relational Health Program Manager at First 3 Years Houston, an organization that educates, advocates, and collaborates to advance the healthy development of infants, toddlers, and their families. Naomi joined First 3 Years in 2019 to support their efforts to build and strengthen the capacity of community-based and healthcare organizations to understand, measure, and address the relational health between parents and very young children using early relational health screening tools. Prior to joining First 3 Years, Naomi designed and implemented an exclusive breastfeeding education program for a women's clinic in rural Haiti. She is passionate about the use of innovative evidence-based methods to improve healthcare for women and children. And then next we have Cal Joubert. Cal is the Fatherhood Involvement Coordinator at Healthy Start UH, who you just heard from this morning. The team uses coordinated care, case management, home visits, outreach, and education to reduce infant and maternal mortality rates, increase access to prenatal care, and remove barriers to service. Cal supports fathers who are enrolled in the program by providing fatherhood education and referrals. We are excited to hear more about his work to involve fathers today. Cal served 12 years as an officer in the United States Marine Corps. Once he completed service, he held several positions within corporate America as a human resources manager and diversity manager for various organizations. So happy Veterans Day, Cal. And our last panelist is Jacqueline McLeland. Jacqueline is the founder and executive director of Push Birth Partners, or PUSH, an organization dedicated to building a trusted partnership and support system for the improvement of maternal health experiences and outcomes before, during, and after pregnancy, no matter someone's zip code. Prior to establishing PUSH, Jacqueline worked in the clinical research industry for over 10 years before becoming a work-at-home mom and the founder of a regulatory compliance service firm. Jacqueline's personal experience, coupled with her education in public health, opened her eyes to the many flaws in our systems and gaps in maternal health outcomes. Jacqueline is also a certified community health worker in the state of Texas and is working towards her legal studies degree specializing in nonprofit organizations. Thank you, Jacqueline. And then our moderator for this panel, Dr. LaChauncey Woodard. Dr. Woodard is the director of the Humana Integrated Health System Sciences Institute at the University of Houston and a University of Houston College of Medicine professor. She is nationally recognized for her extensive research aimed at understanding and medically serving ethnically diverse patients and the socioeconomic factors that influence health outcomes. So Dr. Woodard, take it away. Thank you everybody for being here.
Good morning. It's so great to be here with all of you. I'm looking forward to our discussion today. I want to first start by echoing Jordan's Veterans Day wishes to Cal and to all of our veterans who are joining us here on the call. In my prior life, I was a physician at the Michael E. DeBakey VA Medical Center. So I have worked with veterans for many, many years. And so I'm really pleased that we have the opportunity to celebrate with you today and to talk about these important topics. So I want to say first, welcome to our panel. We're so excited that you all have joined us today. I think that this is incredibly important because we know that this is a critical time for families, especially families from minority communities and lower socioeconomic background, because these communities have really borne the disproportionate burden of the COVID-19 pandemic, experiencing inequities in employment, wage earning, health, well-being, and educational attainment. We've also seen an increase in domestic violence, creating unsafe living conditions for many women and children. So as we continue to discuss issues facing families in Texas, including maternal mortality, how we can best support our young people and our young fathers and address issues that face our children, including inequitable access to quality education and healthcare. I look forward to moderating this panel today and hearing from local leaders who work in this space every day. We encourage you to include any questions that you might have in the chat, and we will try to reserve time to answer those questions. And we also encourage you following this session to join our breakout groups, which will give you an opportunity to have more in-depth conversations around these important issues. So with that, we're going to go ahead and just jump right in and get started. So our first question today is for Mari Carmen. First of all, again, thank you so much for being here. We would love to learn more about the work that you are doing at Texas Working at the Intersection for Safe Families, or Texas Ways. Can you share some of the work that's happening there?
Most definitely. Texas Ways is a cohort of women, Texas women, who have experience in working in the intersection area of domestic violence and child welfare. My Texas Ways sisters, I want to give them a quick shout out. One of them who is actually participating in this panel, Hania Rollins, as a PhD student here at U of H. We also have Eloisa Peda out of Austin. She is a domestic violence advocate and activist. Shelley Ryan, who is a Texas Council on Family Violence Policy Manager. Kim Vincent, who is an attorney and a court-appointed advocate. And we also have District Court Judge Aurora Martinez-Jones. So this group of women, mostly women of color, we came together along with two other cohorts in our country, one based out of Detroit and the other one out of Minneapolis. And we started to look at where we were seeing the greatest impact. The facts are out there. Disproportionately, families of color are being separated by the child welfare system, resulting in greater harm to many of our children, to the victims if they're victims of domestic violence. And so we are working together to look at a way of how to reimagine this system to really truly have better outcomes for the families that need the help the most. So together, not only have we studied for the last 2 years and learned from national leaders in these fields, we also culminated some of our work with the listening session last summer, and that included reaching out to individuals and really hearing their stories to start looking at what those common trends are and what their experiences were with both domestic violence systems and with child welfare to really come up with better solutions. So it's really, really exciting work, but it's only the beginning.
Thank you so much for sharing that. That is incredibly exciting and important work. I want to ask you a follow-up question. Tell us about what you've seen from your work about the intersection of domestic violence and the foster care system, and also about the increase in violence and homicide to pregnant moms. We know we've seen an increase in domestic violence during the pandemic. I think your perspective is very helpful on this.
Most definitely. I think some of the reports show that just in the last year, domestic violence calls increased 10%, right? I know Dr. Sampson was talking about barriers to access systems. Those barriers just grew exponentially during the pandemic. We also know, and maybe some folks may not know this, but maternal health is really important. And I'm so glad that we're talking about how domestic violence impacts that, because some studies indicate that domestic violence is the second highest cause of pregnant mortality next to car wrecks. So really, it is really a high indicator. Most of the lethality assessments that we conduct when we're working with survivors of domestic violence indicate that domestic violence during pregnancy is a high mortality factor where it puts a victim at great danger. So when we're talking about the disproportionate impact to communities of color, when we're talking about the disproportionate impact of the child welfare system removing children from families of color. When we're talking about barriers to access both medical and social services, it really creates a very dangerous situation for many, many of the survivors that we work with, and something that definitely needs to be addressed. In 2020, Texas Council on Family Violence put out a report called Honoring Texas Victims. And in it, it indicated, it really studied and analyzed all of the lethalities in Texas that were a result of intimate partner violence. And in Texas, we had 228 individuals who were murdered by their intimate partners. 183 of those were women. What's really important is that 122 of those women who were murdered were mothers, resulting in 300 adult and minor children losing one or more parent. Of those who lost parents, 59% were minor children, and 11 of the women who were pregnant were killed. So really high statistics. And now I'm like forgetting what the question was. So I hope I've answered at least some of it in terms of the relationship, but definitely it's a really important topic for us to discuss today.
No, I appreciate that. And you definitely answered our question. Also highlighted the intersection of these different issues and how they impact our families, our children, and predominantly when we think about violence, moms. And so we appreciate you sharing those statistics. They really are staggering when you hear them shared. And I had not heard those statistics before you shared them with us today. And I think it highlights the importance of thinking about how we can intervene to change that course. And I hope that many of you will also join our policy panel, where I know some of these topics will also be addressed in thinking about how we can intervene to improve the lives of our families. So thank you so much for that, Mari Carmen. I'm going to shift now to Naomi. I want to ask a question as we're thinking about children and some of the information that Mari Carmen shared with us. In your experience with emotional development and brain development, what are the best interventions to support our families, especially thinking about young children's development?
Great. That's a great question. And good morning, everyone. First, I want to say I'm honored and excited to be on this platform today. And again, thank you to the Hobby School. And then to respond to your question, I believe that some of the elements of good interventions that really support families as well as the social emotional development of children are first family-centered interventions, right? That promote families as partners and parents as experts. And by this, I mean ensuring that family voices are involved from the very beginning, right? So that design and development phase where families can actually have the opportunity to express what they need and expect from systems and providers that their children interact with. And then essentially inviting families to the table to co-develop these programs and services that really guide care and that decision-making. So not including families at the end when we're looking for feedback on the interventions themselves, because what I've learned is that when we really immerse ourselves in the voices of caregivers, it helps us, well, one, better understand family experiences, two, better create targeted interventions, and then it also illuminates our own blind spots, right? So as researchers, as advocates, as clinicians, as teachers, and so forth. Second, I would say are interventions that take a strength-based approach, right? And shift away from that deficit approach that really emphasizes the problem, the pathology, and either what the family is doing wrong or what the child cannot do, right? There are enough institutions and systems for that, but rather recognizing and celebrating the strengths while simultaneously acknowledging, opportunities to provide support by creating service plans based on the specific needs and strengths of the family, right? Rather than trying to fit families into pre-existing service plans. And then last, I would say interventions that are culturally sensitive, right? And take into account possible cultural biases in program designs, access barriers, language barriers, and so forth. And then just to add to that, interventions are important, but really having systems and services that help family-facing professionals identify families that need support is equally important. And so with our early relational health program at First 3 Years, we really aim to enhance the internal capacity of pediatric practices as well as other community organizations to really offer families the support that they need and help strengthen the relationship that they have with their infant and toddlers by leveraging the early relational health screening tools. And so through our trainings, we really help to teach providers how to identify, measure, and address relational health among the families they serve, and teach them skills and strategies to help promote these positive parent-child interactions, which we know the research clearly shows us that, you know, they're key drivers for building social and emotional learning capacities and kindergarten readiness, physical health, and just overall well-being.
Thank you so much for sharing that, Naomi. And I wanted to follow up on a few things that you said. In particular, you talked about how we design interventions rather than assuming that we have the knowledge that is necessary. And I think particularly as an academic institution or in an academic space, or when we think about large healthcare systems, assuming that we have the knowledge and that our communities don't have that same level of knowledge. And what we've seen during the pandemic a lot is that the communities have a tremendous amount of resources. And so thinking about what you said about family-centered, about strength-based, about culturally sensitive, and about co-developed, I think is really important as we think about how we can help to improve you know, our outcomes for our families. And one of the things I wanted to ask you about, because it sounds like a lot of what you're doing sometimes is intersecting with established programs or with healthcare practices. How are you communicating that and working with those systems and practices to bring that approach more to the forefront?
Yeah, I think the first step is one, well, identifying the problem. Two, is also around bringing awareness, right? There are systems that have been put into place, especially when it comes to families and parents, that really focus on more of parenting skills and what the parent is doing or not doing. And I think with relational health, it really takes a different lens and different approach, really looking at the family as a unit. So I think with that, a lot of it is around raising awareness, and also to creating this paradigm shift in thinking, right? Which again takes time, which also requires you to have reflective dialogue and also to ask some challenging questions about what we have been doing and ways we can improve. And again, inviting families to the table to hear from them, include family voices, and really just share that power and knowledge with families as well.
And one last question I want to ask you is, how receptive have you found families to this approach?
Yeah, so I think families have been, I mean, when it comes to early relational screening tool, families have been really receptive to the approach, because as you know, within pediatric practices, when families come in, generally they already have a long list of things in their mind that they think that they're doing wrong, right? And so when they have this opportunity to have a trusted professional who has been trained on highlighting family strengths, families really enjoy that, right? They enjoy having a trusted professional who's able to highlight and say, wow, you're doing a great job. You know, mom, despite everything that's going on, look at how well you're connecting with your baby. So I think in the process of our program, families have been very receptive, one, excited, and I think three, feel seen, right? Feel seen through the process. And I think that's what's really important.
Thank you so much. I think that is really great, and I appreciate you sharing those approaches with us. I'm gonna move to Cal. So Cal does some really important work in thinking about our dads. Oftentimes dads are left out of the conversation or left out of the consideration when we're thinking about how we can support families and create the healthy parents, healthy kids that we're talking about throughout the day today. So Cal, tell us a little bit about what you're hearing in your work with fathers, what you're hearing fathers say that they need in order to support their partners and their families and to be more present and involved.
Okay, I'm back. Can you hear me? Unmute.
Yes, we can hear you, Cal.
Okay, all right. Yeah, my internet had just cut off. So the one thing I've heard repeatedly from the gentleman that I work with is they look they're looking for jobs. I think someone touched on it earlier, Dr. Sampson and Ms. Gillum, about the barriers. It's really hard for a man to feel supportive if he cannot support himself financially. And you know, I think you might have mentioned it earlier also, although a lot of jobs are available, there are a lot of obstacles in these gentlemen finding work. Not just work, meaningful work, in which they can support themselves, they can support their you know, housing needs, food, and all this kind of stuff. So that's been the number one obstacle or barrier that I've experienced talking to these gentlemen.
No, I appreciate that. Thank you so much for sharing that, Cal. And it's interesting because as we've done our work here at the University of Houston and talking to communities, we've heard a lot of the same things when we're talking about, you know, I think particularly for us as a new College of Medicine, going out and talking to the community and saying, what do you need, or how can we support the community or engage with the community or partner with the community? We're hearing a lot about job and workforce development and the need for that in order, as you say, to overcome some of the financial barriers that we have. Also, as you mentioned, right, just from a standpoint of feeling like I'm doing meaningful work and I'm able to contribute in a meaningful way to my family. But I think it's important, as you mentioned, you said there's a lot of jobs out there, but we also know there's a lot of barriers, right, to those jobs, as you mentioned, right? Do we have transportation to get to those jobs, for example? Do we have childcare that allows our kids to be taken care of as we get to those jobs? Can you speak a little bit more to that and what you've heard from the fathers that you're working with?
Right. So I think you brought a good point up. If a young man has a job and doesn't have childcare, and he's a single dad, what's the likelihood that he can hold that job? I.e., if he doesn't have the right information about child support, what to do, his rights as a father. So a lot of these things come to play when you want men to support their partners through pregnancy. You know, and this isn't, you know, just a you know, third ward issue or fourth ward or fifth ward. This is all Greater Houston. So, you know, I've worked with a lot of guys, you know, and as men, we sit around sometimes in the barbershops and just talking about, you know, our issues. And that's a place where we try to, or where I try to go to and create this safe space where we can just talk about issues and do some recruiting. But at the same time, I get a better understanding of what they're, you know, dealing with and what they're struggling with, and then figure out ways that we can all work together and, you know, put them to the right resources.
That's great. Thank you so much for sharing that. And also the importance of, as we're having these conversations, having an awareness and knowledge about the resources that exist so that we can help to connect families with the resources that they need. And I think it goes back to what we heard Naomi saying as well, right? Hearing from the families what it is that they need then allows us to better connect them with the resources that exist in our community.
Right.
So one follow-up question that I had for you, Cal, how do you think fatherhood involvement plays into maternal mortality here in Houston? So we know we have very high rates of maternal mortality here in Texas. And what role do you think fatherhood plays in that?
That's a good question. Great question. I would kind of turn it around and say, what role does fatherhood or fathers play in preventing maternal mortality? And, you know, so let me give you, I speak to guys from a standpoint of connectivity. And I'm a dad of 4. I've been through a lot of this. I never knew, gentlemen, we never know, why was it important to support the mother in breastfeeding? Why was it important to support the mother in encouraging them to go to their prenatal visits? You know, maybe why was it important to support her through the actual delivery of the child? And one we hadn't talked about yet was, as a man, it's important to understand what stress you are feeling. You could have postpartum depression. you're going through a time where, you know, the woman is pregnant, but you don't have a job. So there's some mental issues going on here also. So I talk to the gentlemen, I tell them why it's important to continue to encourage the mothers to go to the prenatal visits, to make sure that if they're high risk pregnancies, to make sure that they are watching their, you know, diabetes or the blood pressure and things like that. And then also why it's important to bond with that child during utero, or once they have the baby, you know, stay in contact, take the parenting classes that we offer, you know, learn about how to hold a baby. A lot of men don't know how to hold infants. I know I did. It was kind of scary to hold that little bitty child in my hand. You know, I don't want to break them. So, you know, sleeping habits, you know, how to pick up on the cues of the infant. So these are things that we can do as men to help support the women before, during, and after pregnancies. And I think that plays a big role in maternal mortality.
Absolutely. I think you highlighted some really important points, and I wanted to just reflect a few of the things that you said. So one, I really appreciated you sharing ways in which fathers can support mothers throughout pregnancy and even in the postpartum period and moving forward. But one of the things that I picked up on that you said is that, you know, fathers are also experiencing some stresses, right? This is a life-changing time for them. They may be experiencing difficulties with employment or otherwise. And so the importance of also, in order for our fathers to be able to support mothers, making sure that our fathers are healthy and well from both a physical and mental health standpoint. So I just wanted to really reflect that, because I heard you say that. And most of what you talked about was that way that dads can support moms, and so important, but also that just realization that it's hard for you to care for someone else if you yourself are struggling. So thank you so much for sharing that with us, and really for sharing your experience, because you're out there every day working with dads. And I think that information that you're hearing and sharing with us is incredibly important.
Well, thank you. Yeah, it's good work. I enjoy doing it. It's a passion. So I know it might not sound like it if I'm, you know, as a Marine officer, and now, you know, kind of compassionate guy, that doesn't go hand in hand all the time, but I really enjoy the work, and I look forward to continuing.
And we appreciate the work that you're doing. And I'm sure that fathers appreciate hearing from you, right? Seeing themselves reflected in you probably makes a huge difference in how they're receiving the information that you're sharing. So really thank you for the work that you're doing, and for sharing that with us.
Thank you.
All right, so we're going to move to Jacqueline. We're so excited to have you here on the panel and want to hear your perspective about why maternal mortality is such a big problem here in the state of Texas. We saved the question for you.
Right. Thank you, everyone. Thank you, Dr. Luttrell, for putting this together, and happy Veterans Day to Cal and everyone who is viewing this conference. So there are so many factors at play when it comes to maternal health, many of which have been covered throughout this presentation. But one of the things that I do want to highlight is what I feel is very important to remember is that we need to refocus our attention back on moms and truly hone in on maternal care. I think that over time we start to put the baby and the infant, which is obviously a very important factor, but that becomes the primary focus, and we neglect the needs of the mom. When mothers are instrumental in creating an environment for themselves, for their families, within the communities, and obviously for the baby to carry that baby throughout their pregnancy, and to carry that baby to a safe and healthy childbirth experience, and even after, in raising that child in a healthy environment. So I definitely think that's a key factor that we need to consider in returning back to focusing on the health of moms. Another factor is here in Texas, we need to consider what is happening in the healthcare industry, specifically with the uninsured versus the insured population. Texas is the #1 state with the highest uninsured population. To take it even further, it's the #1 state with the highest uninsured population of women of childbearing age. That says a lot. That says a lot. If women and families do not have health care, they are not getting the preventative care that they need. They're not getting their wellness checks. They're not getting adequate information from trained medical providers on how to take care of their bodies, or even how to better prepare their bodies for birth. For those who are not pregnant but are looking to become pregnant, if they do not have the health care, they are likely not getting the timely prenatal care that they need, as well as the comprehensive postpartum care that all mothers need. Another aspect is accessibility. Texas is huge. There are many pockets and areas in Texas that lack hospitals as far as distance. Hospitals, clinics, access to obstetrics care, as well as primary care. Many families have to consider looking and driving out to the city, and that is another barrier. Transportation could be an issue, as well as lack of support from employers. People need their jobs. Sometimes moms are afraid, families are afraid to take time off, and employers may not be willing to give time off for them to access medical treatment and medical care. And another factor is, for many communities, there is a lot of distrust as well as mistrust in a healthcare system. That has been a growing concern, and for many communities, it's historical. It's what has happened over time in history. We need to figure out, as a community, as advocates, as clinicians, how do we rebuild that trust so that moms and families feel comfortable going to get the care that they need.
Thank you so much for sharing that, Jacqueline. And so a couple of things that I heard from you is that it's really more than access to healthcare or whether or not you have insurance. That's a huge problem here in Texas. But we heard you talk about a lot of these other social risk factors and social determinants that are impacting whether or not women are able to get the care that they need. And so I think it's important that when we're thinking about this, that we think about this more expansively when we're thinking about our healthcare system, that we're thinking not only about insurance and payment issues, but we're thinking about all of these other issues that allow for mothers to get the care that they need. I see a fact here that, I'm not surprised about, but that the annual report card published by the March of Dimes shows that the state of Texas receives a grade of F for the number of women and children who qualify for Medicaid who are actually enrolled. So that just really, I think, reinforces and highlights the points that you were making, Jacqueline. And I also wanted to say that some of the points that you made, I feel like also reflect what we've heard from Naomi and Mari Carmen about the role of engaging with our communities and our moms to understand what they need. So I want to follow up on what you shared with us. You mentioned the healthcare system and some of the challenges that we face. What are the ways that the healthcare system can be changed to make this issue better for moms and for children in our state?
I think we advocates, appointed officials, we've been fighting the same fight to improve quality healthcare. I think we need to continue. For example, with the Medicaid expansion, it was trickled down to 6 months. It's a start, but we have to do better. I think for many years, we've seen efforts toward getting quality healthcare for everyone. I think that fight needs to continue, but I think it's time for us to look at alternatives. And many of you have already mentioned this. It's now time to bring it to the community. It now needs to be more of a community initiative, and collaboration is so key. Collaborating with community-based organizations and partnering with hospitals, clinicians, invites people with the lived experiences to be part of the conversation, to share what they experience. I think we also need to look at the tracking of data. Dr. Sampson mentioned earlier, there is lag time in the data that we are receiving. We need to figure out a way, how can we track the data, but also comprehensively track those near misses. We need a full picture to understand what is happening so we can know where the gaps are, what needs to be done, and how to better serve the communities going forward and moms going forward. We need that comprehensive picture before, during, and after pregnancy, and we need that data if we're going to improve maternal health, and definitely, again, the collaboration amongst community leaders.
And that's so important, because when we talk about that comprehensive data, what I hear you talking about is not only do we need the data that we traditionally think about that's available through the healthcare system, even though we've heard Dr. Sampson say that there's a lag in that data, we don't just need that data. We need the data that only talking to people can provide, right? Talking to moms and families, talking to community organizations, and understanding what specific communities need, and also understanding, as we heard earlier, that it's not a one size fits all, right? That there may be things that a particular community needs that another community may not need, but they may need a different type of support. So I think to get that comprehensive pictures, we're thinking about not only what we hear from our community, what we hear from the families, but also then what we hear added to that from our healthcare system, and bringing that all together. So thank you so much for sharing that important insight. Now I'm going to take it a little bit more granular, Jacqueline. So we know that we have a problem with maternal mortality very broadly in Texas, but we know that that problem is even worse when we think about Black mothers. So tell me what you think that we can do from a policy standpoint to improve outcomes for women of color, particularly Black mothers who suffer disproportionate morbidity and mortality as related to childbirth?
It's a good question. I think in order for us to implement effective policy, develop effective policy to address these issues for women in general, let alone for women of color, we need to have decision makers who either have that personal experience or that maternal health and women's health experience to help make some of these decisions, or the willingness to listen to those in the communities, to listen to the healthcare providers. In order for us to put policies together that make a difference, we have to be open to hearing what is going on and be willing to process that and look at it from a different perspective. And also creating these policies that are effective for all communities throughout Texas. And again, going back to collaboration, coming together as a team to really hearing what is happening can help us create the training that is necessary, whether it is the cultural humility and sensitivity training. All of that needs to be a consideration, but we can't do it if our leaders are not willing to listen and put maternal health, make it a priority. I think it's obvious that women's health and maternal health has not really been prioritized for quite some time. I think it's time to change that. That's the only way that we can try to make a difference here. And I think that's where it starts. It starts with the right people who are willing to listen, for those who have the experience that can better make these changes.
Thank you so much for that, Jacqueline. And I would amend my question to you because, and I think your answer captured it really well. It's not just about mortality that we see in childbirth, but it's really about maternal health more broadly, and maternal mortality before, during, and after childbirth. So thank you so much for sharing that. And I think what we've heard is also that we need to be able to listen to each other, that we need to be able to recognize the lived experience of a community or of individuals, and then to be able to hear that and use that to guide us as we're thinking about not only interventions, but as we're thinking about policy as well. So I really appreciate you highlighting that for us today. Now, we've had the opportunity to hear from each of our panelists individually and appreciate really all of the very valuable information that you've shared with us. We want to move to some questions that are open for all of our panelists. So feel free to jump in if you hear a question that resonates with you. So we've talked about this a little bit, but I want to ask you specifically, how have the burdens that families have faced before the pandemic been exacerbated by the pandemic?
Dr. Whittier, could you please repeat your question?
I can. So we know that many families faced burdens before the pandemic. So my question is, how has the pandemic exacerbated those challenges that families were facing even before the pandemic started?
Mm-hmm. I think one key thing to keep in mind when we start the conversation is the effect that the pandemic had on the way women birth. So we already had a lot of systemic issues going on with, as I said, the provider interactions and a lot of reported instances of miscommunication, mistrust, not being listened to, that kind of thing. And then we take that existing issue and add to it women having to birth by themselves, not being able to have their partner and or any other support group there, and then having to isolate after they give birth. So one thing I had an eye on the whole time was what that must be doing to the mental health of mothers and to families. And we know that there is a direct link between mental health and physical health. We know that high levels of stress during pregnancy are related to negative birth outcomes and negative infant outcomes even. So that was one thing that I had my eye on. And sure enough, we saw a lot of that, women who are already marginalized being even more cut off from resources and systems. I think I saw Eulalia raise her hand. Sorry about that.
I did. No. I'm going to go to Eulalia next.
I was actually one of the comments that Dr. Sampson made, I'd written down, but what immediately came to mind for me was just exposure to COVID-19 itself and its exacerbation of those pre-existing health conditions that I think society as a whole was dealing with, and then factor into that a woman who is pregnant. Pregnancy does not alleviate or diminish pre-existing health conditions. If anything, it will take anything that's going on in your body and just blow it up. So now add to it this virus and a disease that there's very little information about and a tremendous amount of exposure to, and then the mixed messaging, anything from mask wear, and it still goes on. I mean, just the topic of vaccines. And so I know specifically within the Healthy Start program, even when it comes to that issue, we encourage our program participants, pregnant or not, to have that conversation with their healthcare providers, because we want to ensure that they're receiving the information from those that are medically trained, that they see on a consistent basis, and that hopefully they've established some level of rapport and trust with. But, we've had program participants that have had traumatic birthing experiences beyond the isolation, simply because they were being exposed to COVID-19 and testing positive, and the impact that was having on their bodies, and going into labor prematurely, having to go into intensive care. And so just all of those things, it didn't help. And then oh my gosh, as a program that was attempting to provide services to our families and our program participants, we were disconnected from them physically. We only had the virtual access to them. So to not be able to have that kind of, human to human interaction, or be able to communicate with them while they're in the hospital, and there's just so much fear, it kind of it impacted us. It was frustrating for us, even as service providers, because it's like, oh my gosh, you want to be there, for someone that you're working with and that might be scared, or who has become really ill during a time in their life that ideally, we all want to enjoy, but it turns out to be something other than a pleasurable experience. So just when I think back on it, it's like the PTSD, I guess, comes up because I think about just that frustration of being disconnected from our program participants and from communities in general, and just the exposure to COVID-19 itself and being pregnant. And it turned out to be a scary time for a lot of women. And that's just the pregnant women, the women who've had the babies, even more. It's like, I have this newborn that I am caring for, and out in the world is this global pandemic that's going on. And what do I do? How do I stay safe? How do I protect myself, my infant, my family? And so many questions and not enough answers.
I hear you. Thank you so much for sharing that. Those are really important aspects, and I appreciate your perspective, especially with your work through Healthy Start. So Naomi, I see your hand.
Yeah, so just to, again, echo what everybody else said, but the pandemic has really exposed to a greater degree and really aggravated health and social inequities. And I think what we're seeing and hearing from our families is that they're on survival mode, right? So we have the side where we have the providers, especially in pediatric practices, that are on survival mode, but then also the families, right? They're experiencing disruptions with childcare. They're experiencing, restrictions with physical interactions that has really halted family gatherings and really impacted children's social and support networks. So, grandma, who was maybe once your primary caregiver, you may no longer have access to seeing her because of the risks, right? And then you have parents who are stressed about the additional responsibilities that they have, or adapting to their new roles as educators in the home, right? Or balancing full-time caregiving with their own stressful changes around work and other social situations. And then one thing that I wanted to mention is that we know that if, the adult in the child's world is on survival mode due to, their own adversities or other social determinants of health, they are then less able to provide those positive experiences for their children, right? Those positive experiences that really buffer adversity and encourage resilience. So that's kind of what we're seeing with some of the families that we work with.
Thank you for sharing that, Naomi. I'm going to ask Cal to respond to this one. And then Mari Carmen, I see your hand, but I'm actually going to ask you to respond to our first question from the audience. So Cal, can you add to what we've been discussing?
Right. So prior to me getting this role back in July, what I saw from a man standpoint to my friends and some of their kids is that the pandemic exposed who was really working on the front line. So a lot of the guys that I know, they had to continue to work. A lot of them ended up getting COVID and getting sick and not being able to go home. It was a big problem. Second of all, they didn't have IT technology. They didn't have computers. So doing online Zooms and all that kind of stuff was out the window, right? And they didn't know where to go get the resources. So it was pretty traumatic. I think starting out, things got better, a little better over time, but that's what I saw from a man's perspective that the pandemic kind of brought out and kind of, pulled back that Band-Aid and then really got to look at that scab, because it was really bad from what I saw. So.
Yes, really excellent points that you all make. And I think that our conversation today has really highlighted not only the issues about healthcare, but how all of the social determinants impact our communities and our families and the health and well-being of our families. So I'm going to move to a question from the audience, and I'm going to start with Mari Carmen. And if you want to add to that prior question, feel free to do that as well. But the question from the audience is, you and your organizations are doing such important work. Much of it seems to require intensive engagement with families, women, children, and dads. What are the prospects for scaling up these programs to address the needs of millions of families who need them, and particularly thinking about the resources that would be involved in that in Texas and beyond?
All right. Well, I wanted to start about how the pandemic impacted the victims of domestic violence. As you all know, being stuck in a home and with many of those access points where they were able to contact somebody to have help were not available. So we saw an increase of domestic violence. And then of course, people were not able to call until it was really, really dangerous for survivors. So we did see a big impact during COVID. But to answer the question from the audience, at least for the programs and the organizations that I work with, right, where we provide direct representation or services to survivors of domestic violence and those who are at the interchange of exactly where domestic violence and child welfare intersect. The only way to make those important changes is to have legislation that addresses these issues. That and funding, securing funding that is available so that programs are more easily accessible to those who need them. And then centering the voices of survivors, centering the voices of the families that are impacted by these many different intersectionalities that impact them. So really it's important that both the legislation and the funding be available so that we can continue to do this work and that we can actually give it the importance that it needs.
Thank you so much for sharing that. I wanted to ask Jacqueline or Naomi, did you all have anything that you wanted to add from the perspective of your organizations?
I think, and this was, I think it was either Naomi or Eulalia, the mental health aspect. I think everything that you all have already said leads to that. We have not begun to see the impact of this pandemic. We haven't. And the fact that women, children, even fathers, you know, who may have had access and that out, you know, whether it was going to work or whatnot, but this pandemic forced us into this bubble. And it's driving mothers and families crazy, you know, because we don't know what to expect. You know, moms, you know, have to make decisions, pregnant moms right now with this vaccine. You know, some moms are worried, is this vaccine safe for my baby? There's so many things that families are juggling right now, and it's scary and it creates anxiety. And I think we need to really start to look at mental health issue was a growing concern. This pandemic has exacerbated that. And I think that in, you know, trying to advance and or mitigate the maternal mortality and morbidity, we need to factor in the mental health aspect, because again, I really don't think that we have seen the impact of this pandemic and what it's doing to people mentally and what it's doing to women, mothers, children, and even dads. And I think that's something that, you know, when you talk about the policy aspect, this is something that needs to be brought to the table to our leaders. How can we implement these resources so that families have access to at least talking to someone? Because even that can make a difference. So the mental health aspect is just, it's a huge concern of mine and what it's doing to families in our communities in general.
So important. I think is really important about that also is that you have not only you know, the community experiencing these mental health traumas, but you have the healthcare providers who would actually provide the care for them also experiencing these traumas in parallel. So I think it's really relevant and important what you highlight about policy issues specific to mental health. Naomi, did you want to add to that?
Yes, definitely. I mean, in our work, when we're working with, early relational health screening tools, it's important for us to really leverage existing workforce and reinforce high quality service through recognition and reimbursement, right? And so that, again, relates to, policy and legislation around billing for behavioral health, right? And I think, again, so it again relates to funding and conversations around billing and the misalignment of reimbursement, versus the value of care. So, yeah.
So I want to acknowledge that there are some additional questions from our audience, and we will take those questions. And when we send out information from this recording, make sure that we ask our panelists those questions and provide that information back to you, because we don't want any question to be missed. But I know we are close to time. And so I wanted to end the panel by asking all of our panelists. And so I'm going to ask you for a really quick response, given where we are with time. What are some ways in which our audience members can work to advocate for and advance health equity? And I'm going to ask you each to give me just a quick, answer. And I imagine that some of these will overlap. So I'll start first with Cal.
So I would say, from the role that I am now in, support the men, and it would, of course, send them to our Healthy Start program. But I think it's really just resource connected. I think we have to help men and women in these situations, these communities, get better connectivity to the resources. Provide the information. We just, they just don't know, and you don't know what you don't know. So that would be my short answer to that question.
I appreciate that. Jacqueline.
I was thinking the same. I think building awareness. There's so many people who don't know about Healthy Start, or, the fatherhood program, with Cal, or Push for Partners. If people don't know these organizations and these programs are out there, they're going to be underutilized. The communities that we're out here trying to help may not know. It's just, so build awareness, share something on social media, do something, because you'd be surprised if someone sees that is just what they need. So I think it's a key factor with many of these organizations, especially being nonprofit organizations. We need the help in building awareness that we exist and we are here to help families and women and dads and children. So I think that's a huge help that you all can help us share and let people know that we exist and we're ready to help the community.
I love that. And so all of our participants now have heard about the great work that your organizations are doing, and hopefully they're going to be champions for that and take that back out to the communities that they serve as well. Mari Carmen.
I think one of the importance is that we continue to talk about the intersectionalities of maternal health, and that we convene more conversations like this, because often we are all working in different silos and not connecting all the dots, and that it's really important that we are all having these conversations together, and together, including those who are deeply impacted by this, come up with solutions that really will work and that will cover everybody that's impacted by this issue. So I think really working together and addressing these issues together is what I would want to see come out of this.
Great. Well, I want to thank you all. I know we're at time. I appreciate you all being willing to be here with us and to share your expertise with us. I appreciate our colleagues at the Hobby School for putting on this really important and valuable program. And I want to encourage you all to please consider joining our breakout session so that we can continue this very rich and robust discussion. I promise our participants who submitted questions. We will bring those questions to our panelists and get their perspectives and share those back with you. And then I also want to encourage those of you, because we saw several questions specific to policy, to make sure that you join our session later on today that is focused on just that very topic of what sort of policy implications there are and interventions that we can do to help improve the health of our families and our children.
Thanks so much, LaChauncey, and thank you all of our panelists. That was an incredible panel and session. So excited to share these conversations and have these conversations with y'all. Like we said, please, we have the Zoom link in the chat for joining us for networking and for going a little bit deeper and for participating. If you all want, you're welcome, and that will go till 11, then we'll take a break. And at noon is our legislative panel for this, and we'll come back to the webinar link for that, not the Zoom link. So the webinar link at noon for the legislative panel, and thank you all so much. Hello, everyone. Welcome back on this Veterans Day to our Healthy Families, Healthy Kids Policy, Practice, and Equity for Thriving Young Families event. We had a great morning. This morning, we heard from folks at Healthy Start UH and had a great panel of local impactors who spoke on many facets of maternal, child, and father's health for new families in Harris County and in Texas. And now we have our second Zoom panel, our panel of state legislators. After the legislative panel, we will again meet in the Zoom room, a separate Zoom room like we did this morning. It's a separate Zoom room from the webinar link. And that link to that Zoom room will be in the chat. Y'all are welcome to join. It's an interactive session and where we can meet and network and have time to process and act together on calls to action. We had a great discussion and networking talk in the Zoom before, so I invite you to join this time after this legislative panel as well. So I'm Johanna Luttrell. I'm the Assistant Director of the Elizabeth D. Rockwell Center on Ethics and Leadership at the Hobby School of Public Affairs. And again, this event is co-sponsored by the Rockwell Center and the Center for Civic and Public Policy Improvement. I'll now turn it over to one of our MPP students at the Hobby School, Kate Ranashan, to introduce our panel and our moderator.
Hello and welcome to our second panel of the day. So my name is Kate Ranakin and I am an MPP student here in the Hobby School. After having my daughter, I started learning more through conversations with other parents about the pregnancy, birth, and postpartum experiences and challenges that many people face. And so as a result, I got interested in thinking about ways to improve pregnancy, birth, and postpartum care to better support birth persons and their families. I was also an intern for the Texas Women's Health Caucus during the regular 87th session and was able to see the incredible work of our panelists in action. It is an honor to introduce our panelists today. This panel is a unique opportunity to hear about critical health issues here in Texas from this amazing group of legislative advocates. Representative Donna Howard has served House District 48 in Austin since 2006. Rep. Howard currently serves on the House Appropriations Committee and the State Affairs Committee. She also currently serves as the chair of the Texas Women's Health Caucus. A native of Austin, Rep. Howard earned a bachelor's degree in nursing and a master's degree in health education from the University of Texas. She worked as a critical care nurse at Brackenridge and Seton Hospitals and served as Austin's first hospital-based patient education coordinator. Rep. Howard is a past president of the Texas Nurses Association and was a health education instructor at UT. Rep. Howard is a strong advocate on issues related to public health, the health of women and children, survivors of sexual assault, and public education. Representative Garnett Coleman has served the community of House District 147 here in Houston since 1991. He is currently the ranking senior member of the Public Health Committee, as well as the chairman of the County Affairs Committee. He also has served as the chair of the Legislative Study Group, a nonpartisan House caucus dedicated to the development of sound public policy since 2003. He is also the founder of the Center for Civic and Public Policy Improvement. Throughout his career, he has been a strong advocate for healthcare, economic development, criminal justice reform, and education. Just a few of Rep. Coleman's significant legislative accomplishments include joint authoring legislation to simplify access to children's Medicaid for more than 600,000 children in Texas, securing an increase of $161.5 million for at-risk childcare services, and joint authored legislation to create the Children's Health Insurance Program in Texas. Representative Sean Thierry is the first and only woman to be elected to House District 146 right here in Houston. Rep. Thierry is currently the vice chair of the House Ways and Means Committee and also serves on the Land Resource Management Committee. A strong advocate for her constituents, Rep. Thierry is a champion on issues affecting public health, racial equity, human trafficking, criminal justice reform, mental health, and food insecurity. She has been a critical voice both statewide and nationally for raising awareness on the maternal mortality and morbidity crisis and its disproportionate impact on women of color. Unfortunately, Representative Toni Rose had an in-person Veterans Day event in her district and is no longer able to be with us today. Our moderator for this panel is Dr. Daniel Engster. Dr. Engster is a professor in the Hobby School of Public Affairs, and he is also the director of the Elizabeth D. Rockwell Center on Ethics and Leadership. His research interests include ethics, family policy, early education, and care work. So I'll now turn the panel over to Dr. Engster.
Thank you, Kate, for that introduction, and thanks for your work on organizing this event. I'd also like to thank Dr. Luttrell, Jordan Everett, and Chelsea O'Hara for all their hard work organizing today's event. And thank you, Representatives Howard, Coleman, and Thierry for joining us today for this conversation about recent legislation and legislative initiatives relating to parents and children. I know this is a very important topic for all of you, and one which some of you have been working on for some number of years now. So it's really great to have you all here with us today to talk about this legislation. The goal of today's panel is to learn about recent policy initiatives in the Texas legislature on parents and children, and where, in your opinion, more work still needs to be done. There's a lot to talk about today, so I'd like to get started right away. And ask each of you, I'm going to throw some general questions to each of you, and if you could each keep your comments to around 10 minutes, that would be great, so that we can get to all the important topics that we want to address. After each of you has spoken for about 10 minutes, we'll field some audience questions. Audience, if you have questions, please enter them through the question and answer function at the bottom of your screen. You can enter your questions at any time, and we'll get to as many of them towards the end of today's panel as we can. Yeah, you can enter those questions at any time. So let me jump right into today's session by fielding a question to Representative Howard. Representative Howard, as chair of the Texas Women's Health Caucus, you're ideally positioned to set the stage for us with an overview of the legislative wins and losses for Texas women and families during this session, as well as the special sessions. What, in your opinion, were the biggest wins, near misses, and setbacks? And I'll just let you take it from there, and I have some follow-up questions if needed.
Well, thank you so much. I appreciate being here, and going first in front of Representative Coleman is a little intimidating to me, but I'm going to start anyway and give an overview here from my position as chair of the Women's Health Caucus. But before I even do that, I want to give a shout out to Kate because she was an intern with the Women's Health Caucus, did an outstanding job, was instrumental in helping us with a lot of things, specifically including getting us linked up with some of the grassroots organizations that work on period equity, because we had a bill for the tampon tax, and also doing a lot of background research for us on some of the legislation we had, including scrubbing the bills, looking for points of order, those kinds of things. So her service here was invaluable, and I just want to make sure I thank her and let y'all know how important it is that we have these relationships. Okay, wins and losses. Well, we had a few wins. Unfortunately, I still feel like there were more losses than wins, but I'm going to kind of run through some things that we've jotted down here. And you'll probably hear more about the details of this from Representatives Coleman and Thierry, who were intimately involved in several of the things that I'm going to mention on a real global level here. So, you know, I already mentioned the tampon tax, so let me just go there. This is one that we've had this bill for multiple sessions now and a lot of us look at it in terms of a discriminatory tax policy, in that it obviously impacts only a particular segment of our community. It's a medical necessity. Why are we taxing it when there are so many things that we exempt from taxes? I had some help from Representative Theory, who was on Ways and Means with that legislation. For the first time ever, we did get it passed through Ways and Means with unanimous approval, which was a big step forward. Things are done pretty incrementally here. But we never got it to the House floor, didn't have a vote. But we are working with the Comptroller's Office over the interim to try to determine what the actual fiscal impacts are here and what we can do to anticipate ways to make sure that we don't have a negative impact on the budget by doing this, find other ways to replace that revenue, those kinds of things. So that's kind of what we're looking at over the interim. Postpartum coverage, you're going to hear some more about that for sure. We have the statewide task force that has been looking at maternal morbidity and mortality for several years now. Their number one recommendation over these years has obviously been access to health care is what we need to have in place to have an impact on reducing the high rates of maternal morbidity and mortality that we have in this state. The way it's set up right now, as y'all probably know, that Medicaid cuts off 2 months postpartum, so that even though a lot of those that have just delivered need care longer than that to deal with potential chronic illnesses, as well as the potential of mortality, we're getting lost in the system. We're falling through the gaps here by not having that continuous coverage. And so 12 months postpartum was the recommendation. We fought for that. The panelists you're going to hear from fought for that. We really thought we were going to get there in terms of the House was supportive of it. We passed it out, but unfortunately the Senate only wanted to go to 6 months postpartum. Again, incremental. It's a step forward. We're glad to have it. But quite frankly, as someone on appropriations, it's disturbing to me that we left the session with billions of dollars in surplus and we couldn't fund $40 million more to extend postpartum coverage for a full year. But we're going to come back to fight that. And unfortunately, too, it's because of the timing of things, it's not even going to go into effect until probably 2024. So we're still not doing it now. It's going to be a while before we do it. So women, especially women of color in Texas, are still going to have difficulty with their postpartum care. And let me just put in a side note for myself too. I personally believe that we should have perinatal coverage, because you don't even get the Medicaid coverage until you're already pregnant, which means you've lost out on any of the prenatal care that you might need to have put in place, and even before you've gotten pregnant, to get yourself in a healthy position to have that pregnancy. But that's just me. So I'll move on from that one. Dr. David Lakey, a former commissioner of health in this state, had come to us with an amendment that he wanted to see added to the legislation we considered this summer or fall. I can't even keep up with all the special sessions we've had. The last special session we had when we addressed the federal funding, the ARPA funding that $16 billion that we were going to be using to address a lot of the issues that we have in the state. And we already knew that we were going to be putting some money into the Mental Health Consortium. And Dr. Lakey wanted to see if we could make sure that a part of that would go to a pilot program that they're doing to address the postpartum care of children in the family and of the moms themselves and how they are addressing the kids in their family. So it's related to the postpartum. We got support for that. That did get included. So I'm really happy about that. Another one that I guess I should put this on the law side, but still the one that have been working on for years again too, is to provide CHIP coverage for contraceptives. We're one of only 2 states that currently does not do that. It costs us more to not do that because the funding mechanisms that we use do not reimburse it at as high a level. So the state is leaving money on the table, if you will, by not doing this, but we have not been able to get that through. Again, there's a lot more resistance on the Senate side than on the House side. But this would be a preventive measure that would go a long way toward addressing our high rates of teen pregnancy and repeat teen pregnancies, as well as the foster care system, as well as being more fiscally responsible to do it. We're going to keep working on that one. I don't think I mentioned at the front that the Women's Health Caucus has expanded our breadth and scope beyond what traditionally had been looked at for a variety of reasons. But we have traditionally been really associated with reproductive health care and abortion. We expanded to go way beyond that now to look at the maternal morbidity and mortality situation, to look at expansion of Medicaid, to look at the disproportionate impacts on people of color in terms of healthcare delivery, to look at sexual assaults. And we, session before last, were able to set up in the state of Texas for the first time a sexual assault survivors task force, which has been phenomenal in bringing together all the different stakeholders that work in this field, including survivors themselves. And they had come up with 11 recommendations, and I'm very proud to say that both the House and the Senate passed all 11 of those, which are going to go a long way to strengthening survivor-centered approaches to the whole spectrum of how we deal with sexual assaults in our state. We also had some Medicaid add-on payments for rural hospitals for labor and delivery. I think that's extremely important too, because we know that that's one of the first services to go when rural hospitals are dealing with the financial issues that they have, is the maternal section of their hospital. So this is to try to help that service survive. Real quickly, before I run out of time here, I'll mention the losses, if you will. And again, these will be discussed, I'm sure, further by Representatives Coleman and Thiry. No movement on Medicaid expansion, despite all of our hopes and dreams for this session. You know, we came into this session with a pandemic, thought this is the time. We're finally going to do it. We see what the ramifications are of not having healthcare in all aspects of our state being delivered to Texans. This is the time to finally do it. Plus all of the supplemental payments and the ways this was going to actually make money for the state if we did it. And yet we came up short and we were not able to get that through. It's still just baffling to me. We didn't really have any increase in the women's health programs or early childhood interventions. We, of course, had our usual abortion bills. The three bills that passed this time, one of them is the so-called trigger bill that if Roe v. Wade is overturned, Texas will immediately ban all abortions and make it a felony offense for anyone to provide abortion care. We also had this summer passed Senate Bill 4, which is the Medicaid abortion bill that, rather than following FDA guidelines and medical best practices, limits when medication abortions can be provided instead of up to 10 weeks gestation to only 7 weeks gestation, which is kind of moot in regard to the final bill I'll mention that you have probably heard about since it's been in the national news, is Senate Bill 8, which is a de facto ban on abortion after about 6 weeks gestation. And just real quickly, I know y'all know this, but 6 weeks gestation is 4 weeks pregnancy. Post-fertilization is 2 weeks past your last period if you have regular periods, before many people even know that they are pregnant. It is creating extreme difficulties in our state in terms of people accessing this health care, but it's also spilled over into other obstetrical care. We've heard from physicians who are now having to question their interventions with those who are pregnant and present with some kind of fetal anomaly that is not necessarily threatening the life of the mom, but could potentially do so. It's just mind-boggling what the consequences are here to Texans. And on top of that, this is a constitutional right that all the rest of this country is protected with that constitutional right, except for Texas right now, because of the very strange and unique way that it's being enforced by private cause of action, which is basically bounty hunters, do not even have to have standing. All of these things are going to be culminating in the Supreme Court. We've already been to the Supreme Court once about procedural issues, but we've got the Mississippi case coming up at the 1st of December, which is really going to challenge whether or not Roe v. Wade stands. It will limit abortions to 15 weeks. So all of these things are happening right now, and we're still on top of all this and working on it. But it's been a real setback for women's health care here in our state, and we have a lot more work to do. So I think I'm probably past my 10 minutes. I'll stop talking and let you move on to the next speakers. Thank y'all so much.
Thank you, Representative Howard. That was a wonderful overview. Despite the setbacks that you highlighted, it's also great to highlight the incremental gains and how I've come to learn the legislature often works. That you even when you don't win in one session, you lay the groundwork for a win in the next one. So it's important work that you're all doing, and thank you for all that. And I'm going to turn now to Representative Coleman, who has long been a champion of families and children in the state of Texas. This in previous sessions, he's worked on a number of bills supporting health, equity, and housing for Texas families. And he's also worked a lot on housing issues, housing affordability here in Houston. So I have questions for Representative Coleman on all three of these policy domains, but I would like to start with the one that Representative Howard just mentioned, Medicaid expansion. Can you say a few words about your efforts in this and previous sessions to pass Medicaid expansion, and just to set the stage for those who may not know how Medicaid works in Texas, why Medicaid expansion is particularly important to the health of women, parents, and children here in Texas?
Sure. Well, I had the honor of serving on the White House Working Group of State Legislators for Health Reform under the Obama administration, and worked directly with the House, with the White House on that legislation. And it was very clear that people without health insurance, whether they be children or adults, but in this case, we're talking about adults, that they have an opportunity to get health coverage so that they can have preventative work or care that keeps them from becoming more seriously ill. Also would increase the population public health. It expands that to other areas like CHIP, so that in children's Medicaid, so that there is a robust whole healthcare system that looks at what families need. We hear about social determinants of health and social determinants of housing, social determinants of education, and they all kind of come together in terms of looking at whether a family or the children or parents will be successful. If someone has to move a lot, the likelihood that they have continuity in the education or in jobs or the children's education becomes less. Also, the continuity in healthcare becomes less because of, depending upon the income and where their physician happens to be. But with the Affordable Care Act, I think we're much better off, except for the gap in coverage. And that gap in coverage is that individuals below 100% of the poverty level, really it's like about a little over 100% of the poverty level, are not eligible to be covered under the Affordable Care Act. Someone with a higher income is eligible to be covered for free under the Affordable Care Act and what we call the coverage gap. And those individuals get subsidy for the cost of their health insurance, and allows them to take advantage of the program, whereas someone who has Medicaid coverage, it may, like someone who may not have Medicaid coverage, cannot take advantage of that. We're talking in this case about single men or non-pregnant women. And the pregnant women are only covered, as Representative Howard said very clearly, till now it's 6 months after, I think that's right, Donna? Six months after the birth of a baby. I carried that bill back in like 1997, and we were working on postpartum depression. But the actual legislation is about covering all illnesses that any pregnant woman would have in that first year of the birth of their child, to make sure that if anything happens that's a medical emergency, they're not left without insurance and only using the emergency room as a place for care. And this is one of the reasons why we really do need to do coverage expansion for individuals to get their coverage through the ACA. We may get that. It's not over yet. Finally got the infrastructure bill passed in Washington, and hopefully we can get a social services bill that will include expanding Medicaid for adults in Texas without Texas having to approve that, and that's placed in the federal law. We'll see a lot more happening in Washington, and I hope it's done where it's not too late, and that we can move down that road, because it's obvious in that we're about 9 votes away from, give or take, 9 votes away from passing coverage expansion, which would cover all individuals that are Medicaid eligible in health coverage for adults. The one thing I think that is coming up in Washington, which is important for all of us, is this idea of early childhood education for all 3 and 4-year-olds, and hopefully that can be done, because it makes a very big difference. So if you secure health care for pre-K age children and education for pre-K children, and help parents take care of their household by reducing their costs for early childhood education clearly, and also their own health care and the children's health care, that allows someone to work and be successful. That's why we see that as the norm in many other countries, not here, many other states, but not here. And we'll have to continue working on that. I was saying a little bit earlier, we have to always be optimistic, but I'm wondering if I'm fooling myself. So the reality is, these are things that we cannot give up on. And we get close, and then we pull back a little bit. We get close, we pull back a little bit. And the deal is never to give up, because these are sound, evidence-based policies that educate women and children and husbands and families, and allow them to live a more robust and long life, regardless of their income.
Yeah, well, it is a great perspective you're providing us with, Representative Coleman, and this holistic thinking about healthcare and tying it to housing and education. All these things clearly matter. And this brings me to another question. You filed House Bill 4139 this session to update and expand the work that Health and Human Services Commission does on health disparities in Texas through a new Office of Health Equity. Can you talk a little bit about what this office would do and why it's important?
Yes, the office is a follow-up on a piece of legislation I passed in the 90s that was the Health Disparities Task Force. And what that was to do, and the reason it was called a task force, it would exist forever, but I don't know, maybe I was trying to be sneaky. The idea that we would look at what illnesses pop out or pop up that are significant to people's their gender, their ethnicity, their race, their region, and their income, to make sure that everyone's health and access to health is equitable, so that we don't have a 2 to 3 tiered society when it comes to someone's ability to get care and to know what wellness is all about. Unfortunately, the bill did not pass the House. It did not pass the Senate. It was one of those bills, along with Donna's legislation and other legislation, that was marked as a priority for the House. There is money in the one of the COVID bills that is funding a temporary circumstance. It's actually a lot of money, $40 million circumstance for um, that money will be going to local health departments, but to help them with looking at these disparities. And clearly we learned a lot from COVID about sorry, I got a phone call. Always happens.
All right. Well, we will pause on Representative Coleman there. Oh, you're back. Okay. Do you want to finish up? Okay. I think we'll go ahead and move now to Representative Thiry. Thank you, Representative Coleman, for your work on this legislation and your comments. We'll come back to you with some questions in just a little bit. Representative Thiry, I'd like to ask you if you talk a little bit about the bill you co-authored that Representative Howard mentioned earlier, extending postpartum Medicaid coverage from 2 to 6 months. Maybe just say some words about why and how this change is important for the health of women. And you also sponsored a bill, House Bill 158, to provide Medicaid coverage for doula care. And maybe you could talk a little bit about that bill.
Sure. Thank you all so much for having me today. It's a privilege to join my esteemed colleagues, Representative Coleman and Representative Howard. Honored to sit here with you all today. And thank you to the University of Houston Hobby School of Public Affairs. So let's, I guess, take it from the top. That bill, HB 133, obviously was a step in the right direction. As you've heard today, people have been beating the drums on that for many, many years. However, 6 months it's simply not enough. We know already nationally, the definition, even for maternal mortality, is up to 1 year postpartum. So I always found it kind of odd and shocking that they would just somewhat split the difference and just say, well, it was 2 and we know it should be a year, let's just give them 6. That to me, we know is not sound policy. We just have to be honest about that. Obviously, we were happy to take what we could get. We moved the ball down the field 10 yards at a time, in the legislature. So we know that that will help some moms and some women, but it certainly does not cover the majority of those illnesses that may linger on after 6 months, and those women will not have access to care. So obviously our goal would be to get that back up to 1 year, and that's what we're all as a collective working on. I would like to just say, and then I'll get to the doula bill as well, because the emphasis for that is one of the issues that Chairman Coleman talked about from the beginning when we talk about social determinants of health. Bias, wealth inequality, just have to say it, structural racism, all of that leads to healthcare inequity, healthcare racism. And so lack of access to quality healthcare is really what we're talking about, and fair access, equal access. So all of these lead to the disparities in outcomes for women, but in outcomes for every illness, as you talked about, Rep. Coleman. And so we know all this leads to untreated illness. So that is really what we're talking about: bias, health inequity, and access, racism. So as the impetus for this bill for doula assisted care came from the fact that we know that private healthcare insurance companies now, in a time where health insurance mandates typically go the other way, they are actually seeing that it is a cost saving to allow a pregnant mom to have access to doula care, because they know now they are 4 times less likely to have an underweight baby if they've had doula assistance. They are less likely to require a cesarean section if they've had access to a doula, which we know from a cost standpoint, you go from having a $10,000 pregnancy to possibly a $100,000 pregnancy. So all of these complications are costly for our healthcare system. So private healthcare companies have said, well, you know what, we're going to start to cover that. But for women who don't have access to that, Medicaid moms, it's just simply not available to them. And so I started to work on that. This will be I think it was the third session I worked on it, but this past legislative session, we finally got, as I say, traction and some action. We were able to get the bill out of the committee, get unanimous support out of the House, and it did pass the House. It was going to establish the first ever pilot program to look into how this would essentially work. How would we certify the doulas? How would they get paid? But there was bipartisan support on this bill, and I was very happy about that. We talked about, Rep. Howard talked about, the good, the bad, and the ugly. The good news was, as it related to this small part, the M word was not the bad word, Medicaid. We were talking about it for a very, very subset of women. And remember, they were already on Medicaid. This was just to allow that service, that doula assisted service. So I called it the We Love Doulas bill. I will be bringing it back. We could not get it a hearing in the Senate, but there was bipartisan support in the House for that. And it would go a very, very long way to addressing maternal morbidity, mortality, and other complications, even infant mortality. We know healthy moms have healthy babies. So that's what that was about. One other thing I really want to drive home today is the number one cause of all of this, as it relates to for maternal mortality, is just lack of reliable data. We've been talking about that for so long. Rep. Coleman, Rep. Wiley, Rep. Howard, all of them have been working on this for decades. And so when I came into the ledge in 2017, and I guess we talked about being a little bit of a nerd, I just happened to be sitting in my office one night, and the task force report, Maternal Mortality and Morbidity Task Force, came across my desk, and I read it. And that's when I was mortified to see that Black women were 3 times more likely to die than our counterparts in a pregnancy. Even so, when those Black women actually had access to healthcare, even if those Black women had higher income levels and higher education levels, they were still more likely to die than a white woman who did not have healthcare. So we knew then that there was some implicit bias going on, even when they were similarly situated health-wise. Same height, same weight, all of the same healthcare factors. So that's when I started to really look into that issue. I had almost lost my life during my own pregnancy, and I was a healthy woman, just from getting a high block epidural. It almost killed me. So the biggest issue I found with that, however, is every time we started to try to address the issue, the data was not consistent. And so even now, I want one of the top takeaways from this to be that in 2021, heading to 2022, we're still relying on the data from 2013. So we're about to have decades old data. So one of the other bills that I had been really, really pushing was House Bill 136. This session before that, it might have been House Bill 99, I don't know. But that was to establish the first statewide data registry for maternal mortality and morbidity. There has got to be a way that healthcare providers can look at this information in real time. The state of California has successfully done this, and their numbers, their mortality and morbidity numbers have successfully gone down. So I was looking to create that and got the bill out of the committee. Can't remember if it got on calendars, and then got it on the calendar, ran out of time. But without reliable data, there's just no way that we can really move forward. Now, mind you, even if we get this bill passed next session in 2023, before we could ever implement the data registry, I guess it would be 2025 possibly, and we'd still only have the data from 2013. So I say that to say the urgency of why this is so important. And, we say that, in Texas, our laws are a reflection of our values. And if that's so, then this should happen. If we care about families, that's why I say this isn't a Democrat or Republican issue. If you believe in pro-life and pro-family, you have to be able to support bills and good pieces of policy that support women's healthcare and healthcare for protecting our families and our children. So HB 136 last time is something that I will continue to champion. We want to continue to try to push to get the full 12 months for Medicaid. We want to get this pilot program established so that we can look into paying our doulas and making sure that women who have an income disparity don't have to have a healthcare outcome disparity. They've done this in other states. And so I always say, we'll look back at this in about 10 years and say, remember that time when doulas weren't even covered under Medicaid? Remember that time when we didn't even have a statewide data registry? People were digging up death certificates and records from 10 years ago and trying to piecemeal them together to figure out what went wrong. There will come a time where that will not be the case. So I'm going to take a page out of the old Jesse Jackson book and keep hope alive. We've got some serious champions, as you know, in the House. There will be continue to advance these issues with forums like this. It makes a difference. And so I think from a national perspective too, the work that we've done here in Texas, not just me, all of us, has changed the national narrative and even international narrative. I got a call one day from the BBC and they said, hey, what's going on down there in Texas with maternal mortality and morbidity? So it's unfortunate that America, United States, would be leading in the number of deaths from maternal mortality versus some underdeveloped countries. So that lets us know that we can do better and we must do better. Good news is many of our hospitals have already implemented the AIM safety protocols, the bundles. They've already adopted these protocols on their own. So we are moving in the right direction. And I believe that it's no longer something where when you mention it, you don't get the pushback. It's just that there's always, and my colleagues can talk about this, there's almost so much competition, so what's the hot topic this session? And so I know this last session, we had so much on the plate that was controversial. And when I started to talk about maternal mortality and other things, they were like, didn't we? I thought we did that, Sean. I thought we took care of all that. Did we? I was like, no, we did something, but it's not, the end all be all. There's more work to be done. The doula issue was a little newer, so there was more movement on that. But we'll have to just keep being honest and having these frank conversations. One other piece of legislation I'd like to mention, I didn't get a hearing on it this last session in public health, but I have in the past sessions, and that is the issue of implicit bias training in our mandatory implicit bias training in our medical schools and as a requirement for continuing medical education requirements. I've been a lawyer 26 years. I have mandatory ethics requirements to get my continuing legal education to maintain my bar license. I see implicit bias as an ethical issue. And so there is no reason that that could not be a component of MCE requirements for our physicians, as well as our med students. So we know that those disparities exist. It's not always intentional. So those are my top issues, and I hope you guys got some good top takeaways, and we're open for questions.
Wonderful. Thank you so much for that, Representative Thiry. This is great to have a legislative panel where so many of you are talking about hope or expressing hope. Not exactly what I would have expected, but it's really nice to hear from you all. Also, Representative Thiry, those are just, I'm just astounded to learn that we don't have up to date statistics on maternal mortality. This is one of those things where you just assume this kind of information obviously exists and is accessible until you go and look for it, and then you find, you say, this can't be right. Wait, how come I can't find these statistics from last year? And it's because they don't exist. So that's really an important issue, and thank you for that. So let me speak to the audience and say, if you have questions for the representatives, please put them into the question and answer, and we'll try to get to a couple of those in our remaining time. But before we turn to those audience questions, I'd like to just ask each of you, maybe in say 2 minutes, to address the question of what do you see as the most important legislative initiative or initiatives for supporting healthy parents and children moving forward? And and this is really the emphasis of the question, what can the people who are watching today's panel do to help you and to advocate for these policies during the interim? And I'll start with you, Representative Howard.
You know, I want to be able to maintain that hope. So I'm trying to struggle with my answer with hope in mind. You know, we, as I mentioned a while ago, we have a budget that has a surplus in it. We have, if you count our so-called rainy day fund, we have $25 billion more than we spent that we have available to us. I find that to be shameful in light of the underfunded needs that we have in this state. That being said, we do use accounting mechanisms to balance our budget, and we left session knowing that we were going to owe at least $4 billion more in Medicaid when we come back in a supplemental budget. The reason I'm mentioning all these things is because I'm really focused in appropriations on the dollars. And to me, what's going to drive what actually happens is what we fund. Representative Thiry mentioned that our healthcare policies are a statement of who we are. And we also know that the old statement from way back with Jim Wallace is, you know, a budget is a moral document. And the fact is that we are not covering the things that could help address the inequitable access to healthcare that we've been talking about so far on this panel. We have the ability to do that. I think we need to have honest discussions about our budget, what our priorities are, and quit talking with smoke and mirrors about it, and quit focusing just on budget cuts, tax cuts. That all sounds real good on campaign flyers, but it's not addressing the needs of Texans. And
Hey,
so,
Don,
yeah.
you know what the supplemental appropriation used to be called? The
What?
emergency appropriation.
Oh, emergency.
It was changed when George W. Bush was running for president, so it wouldn't sound like we had an emergency. So Rob Janelle started calling it the supplemental appropriation.
That
So that'll
makes
tell you
sense.
something. Yes,
See, you learn something new every day around here.
every day. Wasn't never such a thing.
But that's what I would say right now.
All right, so since you're on, Representative Coleman, what would you say? How can people get involved? How can they advocate for these issues?
Well, again, try to find the information where you are. If you have cable television, you can get the information. If you don't, you can get it from PBS. You can get it from NPR. You can get it from other types of alternative media in terms of what's needed in our society. You know, clearly you can find out what other places and other states and countries do. But I'm always hopeful that it's never too late to make change. And with that, who would have ever thought that the United States of America would have passed the Affordable Care Act? Who'd have ever thought it? I mean, you know, now we know we couldn't pass a Voting Rights Act today, but one day we will again, and maybe sooner than later. So be hopeful and work towards the change that you want. And that's what we have to do. Otherwise, I'd have left 30 years ago.
You and Representative Thiry, what would you say to that question?
Thank you. I would, I think the first half of your question is what's the number one issues? And so I think equity, you know, if it doesn't matter, we failed as a policymaking body if our policies only benefit the haves and not the have-nots. And we've seen with the COVID-19 pandemic that we are all in the same game. If one community has a high rate of COVID-19, it passes and infects other people. So that's another reason now to address disparities. We have to have equitable healthcare policies. It is the only way we can survive as a state, but also as a nation. So I want to again beat the equity drum that it affects everyone. And then in terms of what you can do, I love the fact now and this is another equity issue, that now you don't have to buy time and know the powers that be. Social media is free, and it's where all the action's at now. And so use the power of your platforms. You know, young people and grassroots organizations now have such strong voices on Twitter and Facebook and Instagram, and they are able to sometimes overnight get something to go viral or in hours. And you start to see how that does impact policy. You know, it impacts corporate policy to where many times corporations back up and take another look at what they're doing when they find out that something is offensive or not popular. So I would encourage people to continue to amplify their voices through the platforms that they have. And I know, social media gets a bad rap, but at least sometimes it can level the playing field. When I went into office, I said I wanted to be a voice for the voiceless. And a lot of times, in the past, the voiceless could not make their voices heard because they didn't have the money. They didn't have the power. So use your platforms. Don't be silent. Organize, mobilize, and stay energized.
Excellent. Thank you. So we have a couple audience questions that I'd like to get to in our last 5 or 6 minutes here. This first question, this is maybe a bit of a technical question, but I hope some of you might have the answer to it. Will the data collected in the newly funded Texas All Payer database include any maternal and infant health data? Do any of you know that? Yeah,
I don't know. That's a good question though, because I'd love to see that. I know Harris County, I will say this, was working to put together our own data registry. Ultimately, we need a statewide data registry. So it's an au pair in terms of, did she say au pair like caregivers au pair?
All payer.
Oh, all pair. I thought she said au pair. Okay. Yeah, I was thinking about doulas and au pairs. That would be interesting to see. The challenge with that, again, is importing that data, and do they have the structural system to contain that, and how because at some point we've got to catch up. That's all I'm saying. We've got to have the infrastructure in place to where we're not looking at data. We're not looking backwards 10 years back. We can get real-time data.
Let me just also add a little off the track here, but I've had legislation almost the entire 15 years I've been here on the MTRAC registry for vaccines to modernize that system. And it would actually save us money again, ultimately, and give us the data we need to make sure we're getting the right vaccine to the right person at the right time, free up bureaucracy, and all the very simple change we're trying to make is to change it from an opt-in to an opt-out, which would make a huge difference. And we would not be having to retrofit our system here in Texas because we are not in sync with the rest of the country. And it had an impact during the pandemic. Again, coming into this session, I thought, this is the time. We all recognize it. The pandemic is here. We need this updated system. We could not get that passed again, even in a pandemic. So this whole thing about registry, huge issue here in Texas, small minority of vocal people who are opposed to registries of all kinds and conflate it with privacy issues and with forcing them to do certain things like get vaccines. We still have a lot of work to do to educate, and we've seen through COVID, we have a lot of work to do to educate people about what science is really saying and about how we're really using data. And I think we're going to have a lot of obstacles in front of us now as a result of all the disinformation that's just occurred through COVID.
The one thing that I would like to add to the statement that you made is we are failing in our public health in Texas. We used to be extremely robust in terms of our collection of data, our morbidity and mortality, what we were doing out there to get ahead of illnesses with efforts like population public health. And as time went on, that money went down, 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 and down. And that's what's so important about the population public health portions of the Affordable Care Act. It's just one thing that we have to remember. I remember when we built the lab, we have a level 4 lab. When we didn't have a level 4 lab, but we paid for a lab in the 90s. It's one of those things that that you have to be interested enough in it to make it happen. And we have just stepped aside on that.
Yeah, thank you. Boy, we're just about out of time. There's some other questions, but I'm afraid we're going to have to move forward. I do want to note that Dr. McLean Sampson notes in the chat, Healthy Start is working to get data to analyze causes of infant and maternal death. Healthy Start will make these findings public once we can do the analysis for all of Harris County. So that's a step in the right direction as well. Now, I want to be mindful of your time and the audience's time. So as much as I would like to go to this, there's a question about Speaker Phelan, the bills put together under the Healthy Families, Healthy Texas. I'll have to leave that aside. Thank you all for a very enlightening and inspiring panel. You covered a huge number of topics in a very short amount of time. So I appreciate you're all speaking so clearly and forcefully on these topics. Once again, I'd like to thank Dr. Luttrell, Jordan Everett, Chelsea O'Hara, and Kate Ranachan for all the work they did in organizing today's event. But it's not yet over. We have a breakout sessions coming up to debrief and further discuss our legislative panel starting in just a few minutes. And so with that, let me hand things over to Dr. Luttrell.
That's right. Thank you. I just want to echo Dr. Engster's thanks to all our panelists, to Representative Howard, Representative Theory, Representative Coleman. Thank you so much for being here. We're so honored to have you. We're so honored to hear your perspectives. And I think our breakout rooms here, I think we're going to talk, one thing we might talk about in terms of action items is how folks who are working locally in communities and NGOs, students, how the public can help get some of these policies enacted and help y'all as well. And so with that, we want to say thank you again, and we can turn to our Zoom link. Our Zoom link is in the chat there, and then we'll go there. And it's good, again, it's a good time to network with folks. And then we won't return here to the webinar. So I'll just say thank you for those of you who are not joining the Zoom link. Thank you again for joining us. It's been a great day. I've learned a ton. And I feel enlivened to continue this work on healthy families and healthy kids. So thank you again. Really appreciate it.
Thank you so much for all you do.
Thank you.
Thank you.